Hello, it's Mark Kris from Memorial Sloan Kettering. Speaking today about neoadjuvant therapy and the new kid on the block, so-called perioperative therapy, where patients receive a neoadjuvant component of therapy that is continued after a successful surgical resection. This was a huge topic of discussion at the recent World Lung Cancer Conference in San Diego, sponsored by the ISLC, the International Study for the Treatment of Lung Cancer. It's, again, just an amazing story that in an almost unprecedented happening, there have been 9 randomized clinical trials conducted all over the world of chemotherapy versus a immune checkpoint inhibitor plus chemotherapy. In most of the trials, one trial of ipilimumab and nivolumab. In every single trial, clear benefit in terms of pathologic complete response rate for the checkpoint inhibitor containing arm, and also an improvement in event-free or disease-free survival. And for those trials that have reported survival data, improvement in survival as well. It's absolutely unprecedented that you would see that consistency, which speaks to it being a biologic fact. And there is something, biologic about it, because it does appear that the checkpoint inhibitors are more effective in the tumor when it is still intact. And people have postulated that having the whole environment of lymph node, primary tumor, and every connection in between makes a difference. Again, that's a theory and not a practice. One huge question is there an advantage to continuing a checkpoint inhibitor after surgery in patients that have received a checkpoint inhibitor and chemotherapy preoperatively? Patrick Ford from Ireland tried to answer this question in the best way we can. There's never been a randomized trial doing that, but there is data from the trials with nivolumab that nivolumab plus chemo alone, or nivolumab plus chemo followed by nivolumab, though both of those trials had the same degree of benefit in the neoadjuvant setting. And what Patrick tried to do was to look at the disease-free survival in the two, and did the continuation of nivolumab after the surgery make a difference? And what he showed was, if you took the time from surgery as the starting point and compared the neoadjuvant alone to the neoadjuvant plus adjuvant, the perioperative, there was some slight improvement with the perioperative. However, if you took people from the date of randomization, there again was that trend, but it wasn't a significant trend. And I think that's understandable, because please remember, on the neoadjuvant arm, every single patient that started therapy was included, whereas on the perioperative arm, people that did not go to surgery for whatever reason, they were not included. So it's only those people that successfully went to surgery that compared their survival. So the jury's still out whether that's true or not. There was additional data presented from the trial of pembrolizumab that perhaps the cut point for benefit of neoadjuvant therapy isn't that 10% number, the MPR, major pathologic response number, or PathCR, and that a benefit, I would say, down to 40, 60% residual tumor. Anything more than that would imply some benefit. So that's another way of trying to decide what patients might need additional therapy. So the jury is still out. There probably will never be a randomized trial. I think there's unbelievably strong evidence that giving chemotherapy plus a checkpoint inhibitor in patients with stage 2 or stage 3 lung cancer, giving it neoadjuvantly is extremely effective. I think today that's our standard for people with stage 2 and stage 3 clinically staged. So what are you going to do nowadays? I think there was some consensus at this meeting, again, not data, that in patients that had a path CR, I think a lot of people would not give any additional adjuvant therapy. Obviously, for patients that had clear disease progression, and I would say you might throw into that group people that had 60% or more remaining viable tumor, those people need a different therapy. That whatever therapy they got was not sufficient enough to give a dramatic benefit. Those people in between the path CR and the 60% viable tumor, that's a tough group. And I know my own practice in those patients, if they have any evidence of mediastinal disease, I give postoperative radiotherapy to the mediastinum. And in general, I've not been recommending additional therapy to those. And again, I've looked to alternative therapies for patients that had a persistent, extensive viable tumor. I think that's in some ways what most people are recommending right now. But again, that's consensus, that's not data. So more confirmation, more agreement that neoadjuvant treatment is the way to go. Giving a checkpoint inhibitor to any patient that doesn't have a driver is the way to go. And chemotherapy.